I think let's put it this way, I think there's quite a lot of people with long COVID who have got an illness which is pretty well indistinguishable from ME/CFS. Now, I was at a research meeting yesterday with a physician who sees a lot of people with long COVID. And his comment was that he thought around about 25% of people he was seeing with long COVID had an illness which was basically indistinguishable from ME/CFS.
You have found the Thinking Mind podcast.
Today I have with me Dr. Charles Shepherd. Dr. Charles Shepherd is a medical doctor and world-renowned expert on the subject of chronic fatigue syndrome, also known as myalgic encephalomyelitis or ME. He is the honorary advisor to the ME Association, which is a self-help support charity for people with ME. He was on the steering committee of the National ME Observatory, a collaborative research project in the UK, as well as previously on the advising committee for the NICE guidelines on ME. He's written a number of books for both patients and medical professionals on the topic, as well as developing the Shepherd ME/CFS disability scale. Dr. Shepherd also developed ME himself following a bout of chickenpox from a patient. Myalgic encephalomyelitis, ME, is a long-term, sometimes fluctuating neurological condition that causes symptoms affecting many body systems, most commonly the nervous system and the immune system. ME affects up to an estimated 264,000 people in the UK and around 17 million people worldwide. There is a 3-to-1 female to male ratio. People with ME experience severe, persistent fatigue associated with post-exertional malaise, the body's inability to recover after expending even small amounts of energy. ME is classified by the World Health Organization, the WHO, as a neurological disease. However, due to the complex and unknown nature of the condition, there has been a lot of controversy surrounding the disease. I feel it's important to mention that my father has suffered with ME for almost 25 years. It's a topic very close to my heart, and throughout our discussion I may be offering some personal experience. Thank you so much for joining us today, Dr. Shepherd. I'm hoping we can discuss what is ME, what causes it, and how do we diagnose it. I also want to discuss how we are treating it. I'm hoping we'll learn a little bit about the history of ME, discussing the PACE trial, which may bring us onto the new NICE guidelines. I hope we can discuss the future of ME treatment and any current important research. And something else I'd like to pick your expert brain on is long COVID. But to start, I've just given a brief overview of ME, but I'd like to know from your own personal experience and professional experience, how would you describe ME?
So from personal experience, we're talking about myalgic encephalomyelitis, obviously. And if you split it down, then you've got myalgic, meaning muscle, encephalo, meaning brain, and itis, meaning inflammation. And it's clearly a name which is disputed by some doctors because of the clear inference that encephalomyelitis means inflammation of the brain and spinal cord. And that's not really proven from any postmortems that we've done. But having said that, I think it is a very good name for describing actually what the key features of this illness are. And I think in very basic, straightforward terms, we're talking about a severe post-infectious, post-viral illness that predominantly, as you said, affects normally fit young adults, 20s, 30s, 40s. And the history that they will give is of being previously well, getting a viral infection, and then not recovering from it. And they have these, what I think are 3 groups of symptoms tying in with this ME. So they have the muscle symptoms, which it's not a tired all the time. It's very much an activity-induced muscle fatigue. It's often combined with muscle pain at the same time. It's as though that you've got a battery which is constantly running flat, far quicker than it ought to be. You may have some other muscle symptoms. Quite often people describe fasciculations, twitchings in the muscle that goes along with it. And then you have this range of brain symptoms. So just as you get muscle fatigue after activity, you get brain fog, brain fatigue after mental activity. You have this cognitive dysfunction. Your brain just doesn't function in its normal fashion. So particularly affecting short-term memory, concentration, attention span, information processing, word finding abilities, these sort of things. And then there are some other brain symptoms as well, which are quite characteristic. I mean, some of them are almost like an inflammatory brain neurological condition like MS, but people get paresthesia, patches of numbness, problems with balance. Hypersensitivity to light and sound is quite common at the severe end of the spectrum. At the severe end of the spectrum, you may even get things like diplopia, and that is very, very rare. And then itis, inflammation, as I say, I don't believe this is what we would normally describe as encephalomyelitis, inflammation widespread of the brain and spinal cord. But I think that there's this range of infective type symptoms which suggest there's some sort of infective, ongoing, perhaps immune system activation response going on, which is causing this ongoing feeling of flu-like, feverishness, sore throats, glands up, just sort of infective type symptoms. So you add them all together and you've really got a pretty nasty, debilitating post-viral illness. Would you like just for me to just talk briefly about my own personal experience?
Yes, please. Yeah, I was going to ask. Please do.
We may dip into the history of this, obviously, as things go on, because it does have an interesting history. And I think the history of this illness describes why many of these controversies and disagreements have arisen. But I think if I take you back to when I was the medical student, which is 40 plus years ago, back in the late 60s, early 1970s. And I trained at the Middlesex Hospital, which has now disappeared. Anyone who knows central London will know that it's become now an office block, although the church does still remain. But I came down to Yorkshire, no history of any sort of illnesses at all. I had a very enjoyable time at the Middlesex as a medical student. But the relevance there was, I think, two things. Like most medical students at that time, there was no mention of this disease. It wasn't something you saw on the wards. It wasn't part of the clinical routine. But it was interesting that while I was there, and I did eventually go on their firms, there were two psychiatrists there called Colin McEverty and Beard. And they became very interested in an outbreak of this disease, because the history going back before 1970 of this illness is one of outbreaks. And there was an outbreak of this illness at the Royal Free Hospital back in 1955, and it was part of an outbreak of a polio-like illness that was going on in northwest London at the time. A large number of hospital staff went down with this polio-like illness at the Royal Free, 292 in total. And in actual fact, the hospital was closed for a period of 6 months between July and November in 1955. And these patients, people who were admitted to the Royal Free, and the staff at the Royal Free, they were written up in the Lancet the following year by a chap called infectious disease consultant who looked after them, called Dr. Melvin Ramsey. And accompanying this description of the Royal Free outbreak was an editorial, and it was an anonymous editorial, but it was actually written by the CMO at the time, Professor Sir Donald Atchison. And the title of the editorial was Benign Myalgic Encephalomyelitis, a New Clinical Entity. And that's where the name came from. And really, that's where this illness entered medical history in the UK.
I see.
And not very much happened following the Lancet papers and the Lancet editorial. I think medical profession largely lost interest in Royal Free and Royal Free disease. But as I say, while I was at the Middlesex doing my medical training, these two psychiatrists got interested in what was happening, what had happened at the Royal Free. And they didn't actually talk to any of the patients of the Royal Free, which is one of the big criticisms of the paper they produced. They rummaged through all the old case notes of these patients and came to the conclusion that Royal Free disease, myalgic encephalomyelitis, was mass hysteria. And so when I left medical school, as I say, didn't see this disease, wasn't really told about it in any clinical terms, but was told that here were two very eminent psychiatrists at your medical school who decided that this was mass hysteria, go away and forget about it. And that's what I did. And that's what most docs of my generation did. They either believed it was mass hysteria or they just didn't know anything about it. I can't recall in the sort of 10 years after that seeing any patients with it. And I just plodded on with my medical career in various hospital medicine posts, including psychiatry. So I do know a little bit about psychiatry. But as I say, about 10 years on, I was actually the resident medical officer at Cirencester Memorial Hospital, which is a large cottage hospital here in the Cotswolds, where GPs do everything under the sun, or they did from sort of orthopedics to pediatrics, obstetrics, and goodness knows what else. And it was a wonderful place to work. And I had a patient who had shingles on the ward. And again, I never had any health problems up to that point, extremely fit, extremely active. And I had this patient with shingles. I'd never caught chickenpox as a child, should have done. And I developed an attack of chickenpox. Now, one of the things that really interests me in relation to what's going on in this illness, and I can still remember this, is that the weekend before my chickenpox spots came out, I just felt completely knackered, fatigue-wise. I had this brain fog. I knew there was something going on. It was really weird. It wasn't flu. I didn't know what was going on. I went back to work on the Monday morning. My colleague said, you're developing chickenpox spots. I think you got chickenpox. You better go home. And that's what I did. And unfortunately, I also had an encephalitic component to this, which is a little bit unusual in the start of this illness, but I had an encephalitic involvement involving my cerebellum, which is what we can get with chickenpox. But like many people with this illness, even today, I spent a fortnight off sick, and then went back to work feeling really pretty grotty. And I think this is where an awful lot of people with this illness go wrong. They don't recover, and this is what's happening with long COVID as well. People get a viral infection, they're knocked off very badly by it, and they're expected to go back to work or education or whatever they do 2 or 3 weeks later, feeling really rough. And I just went through this cycle of going back to work, going sick, going to work, with these fatigue, cognitive dysfunction, infective flu-like symptoms, and not really knowing what was going on. And this went on for ages. And of course, none of my colleagues knew what was going wrong. I didn't know what was going wrong. And I had a really rotten time going off sick, back to work for periods, not even phased return to work like people do these days. And it took me, in those days, it took me 2 years before I actually got a diagnosis of this. And I only got a diagnosis because I actually started reading up about it and thought, well, this Royal-Free disease, this ME, it exactly fits what I want. I got an appointment with Melvin Ramsey at the Royal-Free, who said, well, that's what you've got. You're going to find that lots of doctors won't believe it, won't be interested in it or whatever, but there you are, that's what you've got. And at that point, it was too late to have a period of convalescence and a period of rest and a period of gradually getting back to normal, which is what we're trying to get people to do these days with this illness in its very early stages. That was all too late. And even a period of sort of prolonged rest at that point didn't really have very much effect. I then went up, because we're now sort of in the late 70s, early 80s. And at the time, the only person who was interested in this was Professor of Neurology up at the Institute of Neurological Sciences in Southern General Hospital in Glasgow, called Professor Peter Bean, and he was working with Melvin. And Peter was convinced that this was a genuine serious medical disease. And in fact, he believed it was a neuroimmune disease. And he thought there was 3 components to it. There was possibly a persisting infection component to it. There was a neurological component, an immunological component, 4 components, and that there was a muscular component to it. And the early 80s, I went up to see Peter Bean and got involved in the research that he was doing up there. And I was convinced at the time that there was a muscular component. There was something going wrong within muscle that was causing this muscle fatigue, this very rapid muscle fatigue ability, and possibly something involving the mitochondria, the batteries that produce energy within the cells. As part of that work in the early 80s, I donated some slithers of my own muscle to Peter Bean's wife, Nina Bean, who was a muscle pathologist.
Okay.
And we looked at those under the electron microscope and published these findings, which showed some structural abnormalities in the mitochondria. But what was more interesting, I think more relevant, and is just so annoying from the historical point of view of getting to grips with this illness, I then went down and got involved with a chap called Professor George Rada, who later became, I think, head of the MRC. But anyway, George was head of the magnetic resonance imaging unit at the old Radcliffe Hospital in Oxford, and he was interested in muscle energetics. And so we did some MRS magnetic resonance spectroscopy on my skeletal muscle during exercise. What this showed was that my muscles produced lactic acid at an excessive rate of lactic acid production and very early into exercise. So there was clearly some sort of metabolic mitochondrial energy production problem going on within skeletal muscle. And we published those results in The Lancet in 1984. And as I say, one of the really annoying things was here was a lead to what actually was going wrong in this illness. And it was just impossible to get my medical colleagues to believe that there was something, amiss biomedically. All that just got dissolved away and forgotten about. And we'll come back to this probably later. But I mean, now there's terrific interest in mitochondrial dysfunction in this illness and in long COVID. And lots of people have been producing papers on mitochondrial dysfunction and problems with ATP production and everything else in this. So we've sort of come full circle. But the sort of problems that then started to emerge during the 1980s is that interest in this disease actually started to arise again, both in the UK and in the USA. And I think it was particularly in the USA because there were these outbreaks again, specific places. There was one in Lake Tahoe in the USA. The American physicians, first of all, started thinking this was a chronic Epstein-Barr virus infection. So they started calling it chronic mono. And then lots of United States, UK, and some Australian physicians and people got together. And this is where, sadly, I believe the psychiatrists got involved. As I say, I've worked in hospital psychiatry. Psychiatric illness is real and horrible, just as real and horrible as this is. But I really do believe that psychiatry, through its input into this disease, has halted a lot of the research that should have been taking place much earlier on. But anyway, so we also got the psychiatrists involved in this disease in the 1980s. And they, along with some of my medical colleagues as well, it has to be admitted, they didn't like the term myalgic encephalomyelitis because of this encephalomyelitis, inferring that there was pathology, widespread inflammation going on within the brain and spinal cord. And so we moved away, or they moved away, or they proposed, and really the whole medical establishment swallowed this hook, line and sinker, that we should rename and redefine this disease as chronic fatigue syndrome. And I felt at the time, and still do, and like most people with this illness do, that this is a dreadful term. Because I mean, as I say to people, it's rather like saying that people with dementia have got a chronic forgetfulness syndrome.
It's really frustrating. Even when you Google it now, Wikipedia calls it chronic fatigue syndrome.
Yes. And it's not only that it's a totally unsuitable and unhelpful name for it, it also meant, because they widened the definition of what constituted chronic fatigue syndrome, or ME, it became a sort of dustbin diagnosis for everyone who got undiagnosed chronic fatigue. And as every doctor knows, there's huge numbers of people with undiagnosed chronic fatigue. Chronic fatigue is extremely common. There's a whole range of things that cause chronic fatigue, and I mean, in many cases, there's the combination of emotional factors, physical factors, psychological factors. But we moved away from this really quite sort of tight definition of what ME was, which, despite the name, probably not being the best name for it, I think the way it was described by Melvin Ramsey was actually a very good description of a distinct clinical entity. We moved and widened this to bring in all these other people with chronic fatigue. And at the same time, because there was this lack of interest in the sort of biomedical causation of it, or possible causation of it, it moved towards this model, what has become known as the biopsychosocial model, of, okay, these patients start off with a viral infection, but after that, there's no disease process going on. What is actually maintaining this illness is a combination of abnormal illness behaviors and abnormal illness thoughts about what is going on, and deconditioning. And so you follow on from that, you bring in the management of this with cognitive behavior therapy, which addresses the abnormal illness behavior, the abnormal thoughts, and the graded exercise therapy, which solves the deconditioning. I have to say, my psychiatrist colleagues thought they'd cracked it. This was the answer to people with ME, chronic fatigue syndrome, CBT, graded exercise. And that model kept going really for 20, 30 years. And it has divided medical opinion. It has alienated the patient community for 20 or 30 years. It is a very sad story, I believe, of lost opportunities to get to grips with this illness, to really almost sort of coerce patients into having forms of treatment which don't really work as far as the underlying disease process is concerned.
Mm-hmm.
And as far as graded exercise is concerned, as all the research which was submitted to NICE from the patient community was that around about 50% or even more people were being harmed by graded exercise. So we now, we've reached the point where we now have a new NICE guideline which has abandoned the recommendation for graded exercise and has concluded that while CBT, as it can with many other diseases, long-term chronic conditions, can help people cope with their symptoms and their psychological distress, it is not a treatment for the underlying disease process.
I feel like telling someone with ME to exercise is like telling someone with asthma to sniff dust. It's just going to perpetuate the problem.
Yes. And I will add, because it's something that came up, I was at a help with the all-party parliamentary group on ME at Westminster, and we had a party parliamentary group meeting this afternoon to discuss the NICE guideline. One of the questions that came up at the APPG meeting this afternoon was this business of exercise and whether we antagonistic towards the concept of exercise. And I explained, we're not saying exercise is harmful, we're not trying to ban exercise, but it has to be used in context. And I think the NICE guideline has got it right in that the emphasis is on activity and energy management. But then after that, the NICE guideline goes on to say that for people who are, this is not people in the severe category, but for people who are mobile, moderately affected or even mildly affected and improving, for people who are improving, have stabilized, or improving, getting better, and then want to do something more, then careful guidance on an individual basis, taking into account the way their condition is going to fluctuate, and bringing in some form of exercise. It may be, sort of going for longer walks, going for a swimming in a warm pool, something like that, is perfectly okay. But graded exercise, progressive exercise, on the basis that there is nothing going wrong in your energy production within either, I think, muscle or possibly even centrally within the brain, is just not appropriate form of management for this condition anymore. It is quite unusual for a NICE guideline to recommend a form of treatment for 15 years and then do really a complete U-turn and say this treatment is not only ineffective but potentially harmful. It's quite a significant event.
I know you were on the NICE guidelines committee. Are you able to tell us how we did that 360?
I'm not allowed to disclose what took place in discussions during the NICE guideline committee. That's out of bounds. But the decision was made. It was made after a great deal of thought and consideration. But unlike the first NICE guideline, which really placed clinical trial evidence at the top of their pyramid and really took very little account of anything else, the NICE guideline committee in this instance looked at three tiers of evidence. The clinical trial evidence was the top of the pyramid still. So all the relevant clinical trials were examined in the PACE trial, although trials which included people who did not have post-exertional malaise, which we at NICE and the Institute of Medicine and all the current diagnostic criteria, which are seriously considered, believe is a defining characteristic of this illness. So if you didn't have post-exertional malaise in the diagnostic criteria that the trial was using, and then that trial was either not used or was downgraded. But so all the clinical trial evidence relating to graded exercise was looked at, as for all other treatments, CBT and pharmacological treatments. And the conclusion from the way NICE looked at the clinical trials, which was different form of analysis to the way they looked at them in 2007. They used something called the grade system. The conclusion from the analysis was that as far as efficacy is concerned, the evidence was either low or very low quality. And this was across the board. It wasn't just graded exercise. It's the same thing for CBT, the same for every pharmacological intervention. millions of pounds have been spent on clinical trials over 20 years or so, looking at a whole range of interventions for this illness, and not one of them has produced any sound evidence of a treatment which is safe and efficacious.
That's really upsetting.
It's really upsetting, and I wouldn't say we were unique, but I mean, if you look at these trials, it's really not surprising that they've been graded so badly. You know, the research into this illness from the point of view of just looking at causation and clinical trials has really not been very good. And that is one thing that's really got to improve in the future. So we have no evidence from clinical trials into both pharmacological and non-pharmacological interventions that anything really works in this disease. So on top of that, on top of the review of the clinical trial evidence, the committee also heard from experts. We heard in particular from Professor Jonathan Edwards, who's a real expert in and spent a lot of time looking at clinical trials in ME/CFS from UCL. And then NICE paid a lot of attention this time. It's a criticism that's come from the Royal Colleges, who some of whom are not happy with this new NICE guideline. A lot of notice was taken of patient evidence on this occasion. And we, unusually for a NICE guideline, had 5 patient members on the committee. But NICE also considered evidence which has been carried out by the charities, including the MEA, over many years, collecting evidence from people who've had CBT and graded exercise, which has really consistently shown, really for a long, long time, the same evidence went into the 2002 Chief Medical Officer's report. And it really just keeps repeating this mantra that for most people, CBT is not particularly effective.
I mean, it may be effective in managing the symptoms due to the decrease in quality of life.
Yes. It can help some people. It can help some people cope with symptoms, although the evidence isn't terribly strong from the clinical trials. And it can help people cope with psychological distress. But it's not a treatment or cure for the illness.
Yeah.
And then as far as graded exercise therapy is concerned, I think all the evidence that the patient community has collected, over 50% of people have consistently reported that the way they've been given graded exercise, which, you know, in certain cases has been totally inappropriate and not as it should be in the manuals, has made them worse. So this combination of very poor evidence from clinical trials using the grade system of analysis, the expert evidence on the clinical trials, and the really quite damning evidence from the patient evidence side, the committee decided that it just could no longer recommend graded exercise at all, even with any sort of caveats or whatever. So that has a red line through it. As I say, I think it has moved. Not everyone is happy with it, but I think it has moved to a very sensible way of describing how people should be carrying out activity and energy management in this condition. And then the second part, as I said before, is, I think, very good on how people can progress. If they want to progress, they're capable of progressing to something rather more active, would involve some form of exercise.
I've read the new NICE guidelines, and I appreciate that we've got rid of the graded exercise therapy, but there still really isn't any solid treatment in the guidelines. Where are we at with research right now?
Well, I mean, you know, this really frustrates the patient community. Obviously, it frustrates the medical community who are looking after these patients as well. There is nothing there in the evidence at the moment to suggest that we've got a treatment for the underlying disease, you know, the mechanism that's going on in this illness, whatever that is. There have been promising avenues which have been explored. I mean, perhaps the most interesting one was the use of rituximab, which is a drug which is normally used to treat non-Hodgkin's lymphoma, affects B cells, monoclonal antibody. And Fluge and Meller, the Norwegian researchers who got involved with this a few years ago, found that some of their non-Hodgkin's lymphoma patients who had also ME/CFS had improved following the use of rituximab. And so they did a phase 2 trial, and the results of phase 2 were quite positive. And they went on to do a big phase 3 trial, and that was no benefit. There have been a whole range of other things. All kinds of immunotherapies have been tried. When I was up with Peter Bean, and it's interesting, it's not plasmapheresis, it's apheresis. It is being trialed in long COVID at the moment. But when I was up with Peter Bean in the 1980s, we trialed a whole range of immunotherapies at the time, immunoglobulin, immunovir, and again, none of these things have been shown to work. There's a little bit of evidence from a chap called Montoya over in Stanford in the States that some people who have got a lot of infective type symptoms and laboratory evidence of immune system activation and Epstein-Barr virus titers may respond to something like valganciclovir, the antiviral drug, but that's a small trial, not confirmed. I think the most interesting immunological abnormality in this disease, which may well be playing a role, is this finding of low-level immune system activation that some of these patients have. So,
too low for us to pick up in blood tests.
Yeah. So, and again, this is where there's this interesting overlap with long COVID and the cytokine storm that people with COVID have and may then persist as some form of ongoing immune system activation. So there's a lot of interest and some research evidence, both from blood and spinal fluid, that there is, and neuroimaging studies, that there is a degree of low-level neuroinflammation going on in ME/CFS as a result of this low-level immune system activation. And of course, there are drugs which can dampen down this type of immune system activation that are used in inflammatory conditions like rheumatoid arthritis. And, some small trials have been done in those with not particularly impressive results. But I think that is an area which is worth exploring. At the moment, from the trials that have been done, we don't have a treatment. There are some promising leads from what we know about these different pathological tracks that may be involved, where I think there are potentials to explore therapeutic interventions. I mean, there's an interesting intervention going on at the moment. Dr. Bridget, I think she's Bridget Raman in Oxford, has got a grant to investigate the use of an American drug in long COVID aimed at fatigue in long COVID. This is aimed at improving mitochondrial function, as I understand it. And so we got in touch with her to say, well, look, hey, we've got this massive overlap between people with long COVID fatigue and ME/CFS fatigue, and you've got an American drug company here giving you some money to do this trial. Like, what about having some people with ME/CFS on this trial as well? So I know we're going to talk about this later, but I think the real opening here at the moment, as far as possibly getting some treatment aimed at the underlying disease process in ME/CFS, is what's going on in long COVID, because there's all this money and effort and interest pouring into long COVID at the moment and trying to find treatments for long COVID. And it may well be, if someone does find something useful in the way of treating long COVID, particularly long COVID fatigue, then that may well have implications for ME/CFS.
I mean, are there many differences between what we know about long COVID and ME? Would you say that they potentially could be the same thing?
I think let's put it this way, I think there's quite a lot of people with long COVID who have got an illness which is pretty well indistinguishable from ME/CFS. Now, I was at a research meeting yesterday with a physician who sees a lot of people with long COVID. And his comment was that he thought around about 25% of people he was seeing with long COVID had an illness which was basically indistinguishable from ME/CFS. Now, I got interested in this in May last year, fairly shortly after all this started kicking off, because 3 or 4 months on into the pandemic, we were getting contacted or hearing about people with this long COVID. And in addition to their actual COVID pathology symptoms, their respiratory symptoms, their cardiac symptoms, whatever, liver, kidneys damage caused by COVID, they had a set of symptoms which were really just typical of any post-viral fatigue syndrome, or ME/CFS. So they had the debilitating fatigue, they had cognitive dysfunction. Interestingly enough, quite a lot of them have dysautonomia, so that their autonomic nervous system function is up the creek. So they have orthostatic intolerance, they can't stand up and maintain a standing position very well, which is very typical of ME. They may have postural hypertension, blood pressure dropping on standing. And then there's this interesting group who have POTS, postural orthostatic tachycardia syndrome as well. And they have sleep disturbance, temperature control problems, muscle aches and pains. So they have this wide range of very typical post-viral fatigue syndromes in a lot of cases. So my feeling is that there's probably around about this 25% group of people with long COVID who I think have basically just got ME. And then there's this other group of people with long COVID where it's rather more complex, because they've also got organ damage symptoms from the COVID. So they've got their respiratory symptoms, their shortness of breath, their cough and whatever, chest pains, their cardiac symptoms, their palpitations, they may have had a myocarditis. Some of them have obviously got gastrointestinal involvement, liver involvement, kidney involvement, whatever, skin involvement. So they've got these COVID-related symptoms, which are sort of in a separate box in varying degrees. But we are, at the MEA, we are dealing now with increasing numbers of people who are either coming to us or are part of our social media, because it's very difficult for people with long COVID getting information from the sort of medical charity sector, which functions extremely well in, established diseases like diabetes and MS and whatever, and ME. Although there's a lot of social media stuff for people with long COVID and long COVID Facebook groups and whatever, there aren't long COVID charities providing the sort of information and support that the medical charities for other diseases do. So we are picking up a lot of people now with long COVID and helping them where their long COVID symptoms overlap with ME/CFS.
We've spoken quite a bit about the treatments or the lack of treatments, and you mentioned mitochondria. I was wondering, where else are we at with understanding the deeper cause? I know it's post-viral, but the deeper cause of ME.
Absolutely, it might be helpful because it's a complex subject, and the way I sort of normally split it down is to use something called 3 Ps, because I think there are things which predispose people to this illness, things that precipitate it, and then things that perpetuate it. So those are the 3 Ps. There's certainly some evidence from twin studies, and we know this from anecdotal reports, that there's quite a lot of people in families where there's more than one family member got ME. So I think there is a genetic predisposition to developing this condition when the right trigger factor comes along. That's not unique, because obviously this occurs in heart disease and rheumatoid and everything else under the sun. So we're not unique there, but I think there is this genetic component. And although it's strictly not looking at this genetic component, there is now, and I was involved in the preparation of this, I'm not involved in the study now, but there is now this big study called Decode ME, which we want everyone who's got ME to sign up to, in which people are being asked. It's got £3.2 million from MRC and NIHR, so it's really got good peer review and everything else. And the aim of this study is to collect saliva samples from over 20,000 people. We've got over 20,000 people signed up already. Of course, this can all proceed despite the pandemic going on. So they do this at home, and then the saliva samples go up to Professor Chris Ponting's unit at the University of Edinburgh. They will carry out DNA analysis. So we build up a picture of people's DNA, genetic code, and what is happening in the way of gene expression in this illness as a sort of primary building block to understanding of what. Now, as I say, that's not a study that's primarily looking at genetic predisposition, but it is looking at genetic factors in this condition. I think that the genetic component is certainly there. There's not much else there. I don't think there's any real sound evidence that particular personalities are more predisposed towards getting this. We know, as I think you mentioned in the introduction, it is a female, probably 3-to-1 female to male. There may be something there in the way of immunology, autoimmune disease, like rheumatoid and whatever. that's helping to explain that, I don't know. But I mean, certainly there is that female predominance. But as for anything else, past medical history, there's nothing much. Most people have got a perfectly sound medical history in the past. So difficult to pin anything else down to predisposing. Precipitating, 75% of people will just give this very classic history of, well, viral infection. It's normally viral infection, although some other types of infection, Giardia, can trigger it off. Viral infection, and then just not recovering from that viral infection. Interestingly enough, people say, well, people in Africa don't get this, but they do. They get it following Ebola. There's a very good papers on post-Ebola virus. There's another very interesting infection called chikungunya, which produces this fatigue syndrome. So there's quite a lot of Zika virus as well. So there's quite a lot of exotic viral infections that can produce. Lyme disease is another non-viral one, which has quite a lot of overlap with this. So I think any viral infection is capable of triggering this condition off. Zika virus as well. So there's quite a lot of exotic viral infections that can produce this. Lyme disease is another non-viral one, which has quite a lot of overlap with this. Any viral infection is capable of triggering this condition off. And interestingly, going back to long COVID, back when we had SARS and MERS, we know from the Toronto outbreak of SARS that around about 10% of people there developed an ME/CFS-like illness. So it's not, it's something that we see with coronavirus infections as well. So in most cases, it's this immune system stressor with a viral infection, which people don't recover from. Interestingly enough, I think I've probably got the largest collection of people who develop ME following a vaccination. I have a particular interest in hepatitis B vaccination in health workers. There's something a bit strange about hepatitis B vaccine. In the 2002 Chief Medical Officer's report, we did actually insert this, that we considered the evidence there and considered there was enough evidence to say that it can occasionally be triggered by a vaccination.
Okay.
I mean, from the theoretical point of view, there's not really any reason why if something can be triggered by an infection, it shouldn't be triggered by a vaccination, which is basically mimicking the effect of a infection on the body's immune system.
Mm-hmm.
In the literature, there are certainly cases of this being triggered by vaccination. There's the most recent ones, I think, are some cases of, it was in the BMJ, where people developed it following flu vaccination.
Okay.
But as I say, my series and the surveys that we've done at the ME Association seem to be skewed very heavily, for some strange reason, towards hepatitis B vaccination. And whether this was due to the fact that previous hepatitis B vaccinations were more immunogenic than other vaccines, I don't know. But there has been quite a lot of interest in looking at vaccinations. There's a few people develop it following exposure to things like organophosphate pesticides. They were very much in use in sheep farmers for sheep dipping, probably about 10, 20 years ago. And again, I got quite involved with this with Professor Peter Beirne, because it got known as farmers sheep dipping flu, farmers flu, or sheep dip flu. And quite a lot of people went down, and say around about 20 years ago, when these OPs were quite widely used. There's a colleague of mine in Australia, Professor Pern, who's very interested in what's called ciguatera fish poisoning. And he has described people who got an ME/CFS-like syndrome following ciguatera fish poisoning, which messes around with sodium ion channels. So vaccinations, pesticides, very, very occasionally some form of major traumatic event like a major surgical operation, sometimes following pregnancy. Rare, but occasional. And then we just have this other group who don't follow any particular pattern. They can't predate it to a very specific event. They may give a sort of history of repeated infections, repeated bouts of ill health, which get sort of more progressive over time. And they're more of a mystery.
People don't always have symptoms from viruses, though. I mean, take COVID, for example.
Exactly.
So it's not to say that they didn't have a virus that caused it.
That's
they just
right.
may have been asymptomatic.
Yeah. that may well have been the case. And then the third P is what then perpetuates it, keeps it going. And indicated earlier that these sort of 4 or 5 avenues of thought, there's the persisting viral infection thought, and I think we've really debunked that back in the sort of 70s and 80s when Peter Byrne and a colleague of his called John Gow, who was a virologist, were very interested in this, and they're particularly interested in looking at enteroviral infections in this. They did a lot of work on this because they thought initially that there could be a persistent enteroviral infection. But in actual fact, their studies really debunked the idea that we were dealing with a persistent enteroviral infection. However, there is a physician, and I've met him and seen him speak at conferences, published papers, called John Cheer over in the States, who does believe that this is certainly in some people, a persisting enteroviral infection, and he's cultured enteroviral infection from gut biopsy samples and things. But I think overall the evidence is now very much against persisting viral infection. Where I think that the evidence is much more stronger and consistent is this idea that you get your viral infection, you produce a rather overactive immune response, as may well be happening in people with COVID, and this overactive immune system response doesn't then switch off. So you have this low-level immune system activation going on, which is supported by a certain degree of evidence, and that this is having an effect on certain control centers in the brain. So it's upsetting control centers which are organizing autonomic nervous system function, sleep, particularly hypothalamic function, and other control centers in the brain. And maybe a colleague of mine in the States, Tony Komaroff, believes that there may be some sort of fatigue center in the brain, because I think not only is there this peripheral muscle fatigue in this illness, but I think there's central brain fatigue going on that you get in a lot of neurological conditions like MS, Parkinson's, and even brain trauma, brain injury. So I think the fatigue probably has what we call central and peripheral components to it. And then there's also this muscle component to it in the mitochondrial dysfunction, and that could be again cytokine induced, because we know that if you have raised levels of things like interleukin-6, they can have an effect on muscle function, and you can get post-viral mitochondrial myopathies. So it's far more complex than that, obviously, but I think in very simple terms, we may be dealing with something that involves viral infections triggering it off, immune system activation which is not settling down, abnormalities in brain function rather than brain structure, and a disturbance in muscle energy metabolism within the mitochondria. And I mean, that's the main focus of most of the research that's going on at the moment, trying to tease these things out.
You mentioned when you got it as well, you were kind of forcing yourself back into work. And my father was in the same situation. He had the flu. He also got Bell's palsy and then tried to continue going when he was unwell. Yeah. Is that something you've seen common in people with ME?
I've seen it very, very commonly. And although we never had the opportunity to do any sort of research on this and say, well, look, that approach to management is just so bad, and it's what makes people have a more persistent and chronic illness with this when they've got a viral infection. All the anecdotal evidence suggests that these people like me, your father, who have not convalesced and had a period of rest and then gradual return to normal activities, are just not giving themselves a chance to recover from this illness or improve from this illness. And I think when you get the management so badly wrong as I did, sounds like your father probably did as well.
I don't think he got any management. I think that was probably the issue.
Either no management or bad management.
Or no diagnosis for a long time as well.
Yes, I had no diagnosis, bad management. Yeah. I mean, it was self-inflicted bad management.
It's difficult, though, because you want to continue with life.
Yeah, you do, yes. And I mean, you know what it's like if you're a doctor. You don't go off sick.
Yeah, exactly.
You just carry on with whatever you've got.
And you just assume it will get better.
Natural response, and you just assume that things will get better. So, it was 2 years, in my own case, before meeting Melvin Ramsey and Peter Byrne, being told about pacing and sensible approach to activity and energy management, things did click into place. And I mean, on a more positive note, once I started to pace myself properly, although it was 2 years or so on into the illness, I did then start to make some improvement, and I made gradual. It was rather erratic improvement, but gradually I made improvement, progressive improvement over a number of years. Never got back to full normal health. Probably functioned about 70%, I would say, of normal physical and mental health, and I've been, I think, pretty lucky in that respect. A lot of people haven't, but like an awful lot of people with this illness, you reach this sort of glass ceiling.
You get to learn the new normal.
You bob around that. You get another. I mean, the main thing that causes relapse in this illness is get another infection. I occasionally pick up a nasty infection, and that will plunge me right back down to the bottom again. It takes a bit of time to get up, but most of the time I just hover around this 70% mark. And I think for people, quite a lot of people who are in the sort of mild, moderate category, mild is an awful description of this illness, because if you got it and you were affected by it, it's a life-changing illness. It's not a mild illness, but mild describes people who are vertical most of the day and carrying on to some degree with normal life. At the other end of the spectrum, which we really must mention, is the fact that we've got around about 25% of people with this illness who are, and I'm glad that we put this into the NICE guideline, this distinction, who are either severe or very severe, because there are people who are severe, who are housebound, wheelchair bound, bed bound some of the time, but at the very end of the spectrum, and this is something which is really tragic, because these people are really totally neglected by medical services in many cases. The very severe end of the spectrum, these people are totally bed bound, and they may have to be on tube feeding, and they are basically paralyzed, and they're often devoid of any sort of meaningful medical or social care input, and they struggle to get this input. And even where we have got a patchy network of specialist referral services at the moment, which is hopefully going to improve following the NICE guideline, but very few of these specialist services offer any sort of domiciliary service going out to people who are severely affected in their own homes. And at the same time, we only have one unit in the whole country that has dedicated inpatient beds for taking in people with severe ME for further assessment.
What percentage of people suffer with that severe ME that you've described?
Yeah, well, I mean, we haven't got any real figures on it, because no one's really done the research to get the epidemiology there on the figures. The best guess that everyone uses is 25. I say 25% of people at any time, because I don't think 25% are severely affected as a permanent basis, but I think 25% probably at some stage in their illness. People who are, I think we would classify as very severe, who are totally dependent, totally bed bound, I think we're probably talking about 5%, but it's difficult to say, because they're severely neglected as well, and they're hidden away, and we just don't know. We just don't have the figures on.
Another thing I kind of wanted to speak about, we don't have much long left, but I wanted to talk about the controversy around ME, because it's hard to diagnose. Do you think people abuse that and use the diagnosis for secondary gains when they're not really suffering with what we would consider ME?
I think that's very, very, very unusual for that way around. I think the major problem is people just not getting an early and accurate diagnosis. And that is something that has really been, I think, addressed very, very well in the new NICE guideline, because it not only has a section which some of us pushed very hard for, this whole business about what you do with people who've had a viral infection and then are not recovering after 2 to 3 weeks. What do you say to them? So there is a whole section now in the new guideline on this period of what's called in the guidelines suspecting ME/CFS. So if you've got someone who's had a viral infection, who's normally fit and well, and who's not really getting back to normal activities within 3 or 4 weeks, and is functionally impaired 50% or more, then you really should be suspecting ME/CFS. and going through the procedure of trying to make sure you're not dealing with something else, so all these routine blood tests and everything else, but most importantly, actually providing some sensible advice on activity energy management. And I think we actually use the term, I'm really, it's a term which went out of fashion in medical parlance, but I think it's a really good term, and having a period of convalescence. And then aiming to make a diagnosis. The aim in the guideline is now, and this is not what all the research criteria, diagnostic criteria say, because they normally say you've got to have 6 months before you diagnose ME/CFS. We are saying, as the MEA has always said, that most people, you should be aiming to make a diagnosis within 3 months of the onset of symptoms. So early diagnosis, careful consideration of other things that could be causing ME/CFS like symptoms. And I think the other side of it, people misusing ME, because you don't get much gain from having ME. You're going to struggle to get benefits. You're not going to get you may not get any sympathy from the employer. It's difficult to see what people can actually gain.
You mentioned benefits, because I know you're on the APPG board. How easy is it to get help from the government if you suffer with ME?
Well, the DW, because I've worked with the DWP on this issue for 20 odd years, and I mean, as far as all the official stuff that comes out of the DWP is concerned, and I have to say, I also work quite closely with a company called Maximus, and they're one of these organisations that do the medical assessments for employment and support allowance. I think their guidance is pretty clear that this is a genuine medical condition and that people are entitled to PIP, personal independence payments, employment support allowance, if they meet the criteria. The problem with getting these benefits for many people with ME/CFS, as we've raised numerous times with ministers and everyone else, is the way that the eligibility criteria apply to people and the way people are assessed for benefits. And you are to a certain extent assessed in this awful sort of snapshot, what you can do on the day at a particular time. And, if you can lift a pack of flour and put it on a shelf, if you can bend down, if you can walk 200 yards, that's fine. You tick boxed, you're okay on that task. What it doesn't assess is the fact that can you repeatedly, safely, sustainability, carry on doing these sort of tasks throughout the day, which of course the person with ME/CFS can't. So there are major problems with the underlying criteria, but it is very clear from what the DWP and organisations like ATOS and Capita and Maximus that assess people say that people should be able to get these benefits, but they fall down because of the way the descriptors, the tasks that people have to perform or not perform, are designed by DWP. So a lot of people do have problems with benefits. We actually advise people, if you've been turned down for any benefit, if you've got a good case, go to appeal, because we know that round about sort of 30-40% of people succeed on appeal if they produce then some good supportive medical evidence.
I think I have to say, when I was studying at med school, which wasn't that long ago, I went to UCL and I graduated 5 years ago. When chronic fatigue syndrome, which was what it was taught to us, was not well taught, and I paid a particular awareness to it because my father has ME. I call it ME. And I know a lot of my colleagues still consider it a kind of made-up disease. What would you say to medical professionals who have that opinion?
I would say listen to your colleagues, some of your colleagues who've got this, and also listen to some of your colleagues who've now got long COVID, because there's a lot of doctors with long COVID who are describing the same range of symptoms and the same problems that these symptoms are creating, and actually, generally speaking, getting quite a lot of sympathy. And I would say it's not really any different. They've just got a severe post-viral illness, just like people with ME/CFS is concerned. What I would also ask them to do, because I work very closely, I don't know whether you've heard of a lady called Nina Muirhead, Nina Muirhead is a dermatology surgeon. She deals with dermatology cancer most of the time. And she went down with this. She's an Oxford graduate. And she went down with this at quite an early stage in her career. She was in a wheelchair. She'd had exactly the same experience at medical school of, not being told anything about it, same problems with diagnosis and everything else. Nina has made really quite a lot of, she's not recovered, but she's made quite a lot of improvement, and she's back at work now. And Nina also has a post at Cardiff in academic medicine in relation to medical education. And she has produced a very good CPD learning module. It's on PRN, I think it is PRN learning on this subject. And she's also done some video work with me and other people to sort of highlight this. So I would think have a listen to some colleagues who've gone down with this, especially young, fit medical colleagues. Read the NICE guideline. And as it says in the NICE guideline, listen to your patients, believe your patients, and have empathy with your patients when they come along with these strange symptoms.
You are listening to the Thinking Mind podcast. Thank you so much for listening to this episode. If you enjoyed it, please share it with a friend or give us a rating. It really does help people to find us. If you find the podcast valuable, why not buy us a coffee to help keep us going? There's a link in the show notes. As ever, we love to hear from you and love to hear what you think. So drop us an email or get in touch on social media. Thank you so much.